It came about very much through the back door. I was board certified in internal medicine and working in a kind of traditional internal medicine clinic. And I would have to say a very heavy percentage of my patients were geriatric age.
It's for the greater good. Hi, Amy. Life is good. Amani, hello. You guys have any questions for me while we deal with some tech issues? I'm excited to talk to Dr. Chamberlain. I love talking about hospice and palliative care medicine. We've had one hospice specialist on before, BJ. What's BJ's last name? I always forget. BJ Miller. I love BJ Miller. He was one of our earlier guests. No, I'm not Meredith Gray's long lost brother, unfortunately. Side note, I love your podcast. I'm not listening. Thanks, David. Amy, Thanksgiving plans? No, just hanging out with family. Nothing special. Yes, Emily, scribing is clinical experience. All right. Yes, Linda, BJ was awesome. How's the weather? It's a little cold today. See, I'm wearing my fleece tonight. Just staying a little warm today. All right. Dr. Chamberlain's back.
Okay, it's a miracle.
Hey! We can see you. We can hear you. You can hear me. You can hopefully see me, although you don't need to see me. But yeah, excited to have you here tonight.
Thank you. I'm excited to finally make it.
You were here. Your devices just didn't want to play along for a little bit, but yeah. It's good to get you on here. We were just talking about hospice and palliative care. I was just saying I'm looking forward to chat with you because it's one of my favorite specialties to talk about because it's not known enough, yet makes such a huge impact for patients and families. And one of my earliest sessions of e-shadowing was with Dr. BJ Miller, a more popular in the mainstream of things, hospice and palliative care doc. So I'm hoping to have a great conversation with you as well. Let's start with your initial interest in hospice and palliative care.
It came about very much through the back door. I was board certified in internal medicine and working in a kind of traditional internal medicine clinic. And I would have to say a very heavy percentage of my patients were geriatric age. And over time, I began to see a real trend of elderly patients who had lost function and lost quality of life because of chronic pain. And, there's this bizarre dichotomy out there. It's gotten a little better now, but if it's cancer-related pain, well, that's important, and we want to aggressively treat that. But if it's non-cancer pain, that's not as sexy, and it gets really kind of pushed to the back. And so I was seeing a lot of folks and often covering for my partners, and they're just on kind of these low doses of stupid, low dose mixed drugs like narco, hydrocodone with acetaminophen, occasionally oxycodone with acetaminophen. And it was just inadequate. Often they were verging on overdoses of Tylenol. And I just thought, this is a group that needs someone to really pay attention to them. So I went out and really self-educated on non-invasive pain management. I connected with a physical therapy group to help my patients, and also connected with an anesthesiology group that could do procedural interventions, and begin using, applying these principles, especially long-acting, extended release types of medicines, and just had remarkable response. It was just great to have, an elderly lady come in and in a wheelchair. She can't do shopping, which is the thing she loved most of all. And just the fact that I said, I think we can help you, get you completely back, but I certainly can improve your quality of life. And just making that offer, she just broke into tears in my office. And with pain management and with physical therapy, we got her, one of the things I do with pain management particularly is, what would you like to do that you can't do because you're in pain? Mm-hmm. And her activity was shopping. She just loved pushing the cart around the grocery store because she knew everybody in the area and it was a very social event for her. So that was our goal, and we got her there. And it was a dramatic change in her quality of life. And that was just very rewarding for me. In an internal medicine clinic, it's interesting. There's a lot of different things that come in, but when you're in an outpatient clinic, you also get a lot of stuff that it's relatively minor. I've got a stomach ache, I've got a rash, and suddenly I did something that changed a person's life. Mm-hmm. And that felt great. That was what I got into medicine to do. Yeah. And I progressed with that. And then at one point I got a phone call from a hospice agency. And, I trained in the Army and then joined this clinic, and I really had almost no concept of what hospice was, other than that's where dying go to die. Mm-hmm. And they called me up and they said, we've got a lot of patients here in pain, and some of them have just come from you, and we really like, nobody's doing that sort of thing. Mm-hmm. Would you mind helping us out? And I was doing a 4-day a week and 1 day off clinic schedule. So I said, sure, I'll come by, spend half a day on my day off, and got just absolutely hooked. The elderly, and then when you take the elderly and advance them into not just elderly, but chronically ill and declining, really it's the last great disenfranchised population with respect to healthcare. They can't get to doctors. People are afraid to medicate them, or they are afraid to stop medications that, these folks come in on 10 medicines, and you're thinking, you're 85, you never had heart problems. Why are you on a cholesterol medicine? So to be able to come to this group to clean up their medicines, which actually in some cases got them off hospice because they were just having so many side effects from the medicines they were on. Yeah. But then to be able to aggressively treat their symptoms, and frequently I was making house calls, which that is an incredible experience because they're just like, wow, a doctor came to my house. Who does that? And we're talking like 20 years ago, really, when this started for me. And I just loved it. And I stayed with that company for a while. And finally, I kept increasing the amount of hospice time and decreasing the amount of clinic time. And the clinic finally said, you need to make a decision here. And at that time, the hospice, which was a national hospice agency, hired me to become their national medical director. So I went full-time into hospice. So that's how it got started. And because of our location, I've had a number of jobs. I have been doing hospice and palliative care continuously since then, but not always full-time. Mm. But it's been a terrifically rewarding career for me.
That's amazing. So talk about, and you kind of mentioned this, was your experience obviously coming from the Army, which isn't as good as the Air Force, I'm sorry to say.
My son's in the Air Force, so that's okay.
Right.
He's doing a radiology fellowship.
I was a flight surgeon in the Air Force for a few years. So you mentioned coming from the Army, your perception of hospice was, that's where those who are dying go. That's a pervasive myth that continues to kind of cause a lot of people to avoid hospice and palliative care. Talk about that myth and how do we fix that in the healthcare world so that medical students coming through and pre-meds that are watching now can potentially keep an eye on hospice and palliative care as a specialty to take care of patients.
Yeah, there's a couple of points in what you've said. Most people have heard of hospice. Most people haven't heard of palliative care, or if they have, they think it's hospice.
Mm-hmm.
So the first step with respect to hospice, not just community patients and families, but most doctors are reluctant to refer to hospice because, they're not actively dying yet.
Yep.
And, to try and provide the education, and I've done a lot of lecturing to say, you don't have to be on your deathbed. It's kind of intended as at least as a 6-month benefit. And Medicare has given us some criteria that are pretty good. And I look at the Medicare hospice benefit is really one of the great government benefits out there. There aren't, there's a lot of junk, but this is a terrific benefit. And I presented to families, my general spiel, if I'm going there, is I say, I'm going to say a scary word, and you've probably heard of it, but before you react, let me explain. And I then present the benefit, and especially I present it as a way not just to help the patient, but as a support system for the family and as a safety net, so that something goes wrong in the middle of the night, you don't have to try to rush to the emergency room or call 911. You can call a hospice nurse who has a hospice doctor backing her up 24/7. So not just is it a great benefit, is it the experts at pain and symptom management and end of life care, but it is a tremendous support for family members. The most common thing I hear is, why didn't I know about this sooner? Why didn't somebody send me there sooner? So that's a terrific thing. And palliative care, the description I generally use is palliative care is a basket of fruit and hospice is an apple in the basket. So hospice is a part of palliative care, but palliative care is a much larger thing. Mm-hmm. And, in my career, I have been part of, I would say, almost all three aspects, really, because I've worked a lot in the world of hospice specifically. But a number of years ago, I had an outpatient, basically a house call program where I was going to see elderly patients, and I tried not to let it become primary care. Often, the goal was to become a consultant, to do medication reviews, and then address symptom management and functional improvement. But that was awkward just because you spend so much time behind the wheel. Windshield time is painful. And then for the previous 3 years, prior to this year, I was doing exclusively inpatient palliative care. And that, especially during COVID, the vast majority of that was what we call in palliative care is our procedure, which is the family meeting. And we spent a lot of time talking to patients and families about goals of care. Often for me, I was spending a lot of time in the intensive care unit talking to patients and families and trying to come to some kind of consensus about where do we go from here? When is enough? And those can be very challenging, but they're so necessary. And, I see, one of the intensivists come walking by and they pop in the room and they spend 3 minutes and then they pop out and say, yeah, they want to keep doing everything. And I'm like, there's no way you had that conversation, that they just no. So, normally when I would get a consult, it could be an hour long, just talking with the family and sometimes just preparing the ground and then setting up the next meeting. But it was dramatic for family members to be able to air their concerns, to be able to, I consider part of the job communication, because especially in the hospital, but also in other environments, doctors tragically, and this is a generality, but it's one that I've encountered frequently, doctors don't communicate well. They use a lot of jargon. Yep. They use a lot of euphemisms. They are, it's difficult for many doctors to just be straight with patients and say, you know what, not going to get better from this. This is a massive stroke, and yes, we can keep this body alive for who knows how long using all kinds of artificial interventions, but the person you knew is never coming back, and this is the best it's going to be. And instead they, the other doctors come by and, oh yeah, the kidney function's a little better today. And the family's like, oh, hey, and then the nurse says, hey, the urine output, it's bumped up a little bit. And you're like, so they keep getting all these positive, trivial comments about the care, but nobody's come right out and said,
yeah,
this isn't going to go a good place.
Yeah.
So they need to hear that.
Two questions, and I'll ask them separately, as good doctors should ask questions apart. How do you handle patients who hear you but don't hear you because they've read on Facebook or they've heard through the grapevines this one person who was on ECMO for 6 months, specifically talking about COVID here, ECMO for 6 months and in the ICU for a year and was extubated and went home?
What I generally say, if assuming the patient's not able to participate in the conversation, first we say, I ask the family, what did your relative, your whoever, your loved one, did they ever talk about what they would want? And as a side note, with all my patients, I encourage them to have these conversations. I mean, now I work with exclusively cancer patients, and even if it's a minor cancer patient, I talk to them about advanced care planning because that's the best thing. And but otherwise, I just talk about quality of life. What did your dad like to do? Well, he liked to go out and he liked to hunt and he liked to golf and he liked to do these things. And I would say, well, he's never going to be able to do that again. Your dad's life right now is going to, and now and for the foreseeable future. And I'm very blunt, once I've established some kind of rapport with the family, I don't just walk in and say, Dad's dying, let's move on. You talk to them. I often in a family meeting will say, we'll introduce each other and I'll say, I want to bring the patient into the room metaphorically. So I need you all to tell me about him. What does he like? What does he do? And that often brings people to tears and creates a little bit more trust and puts the onus not on what do they want, but we're now talking about what the patient wants. Yeah. Does it work every time? No, but I did have a lot of, and I hate to use the term success, but in coming to grips with the family and being able to achieve a realistic plan of care for where we were going from here. Not always, some people are like, he's a fighter. He wants to go forever. Keep going. Yep. I say, well, okay.
Yeah, but I've heard that. And dealing with COVID last year, my grandfather unfortunately got COVID and passed. But in that process, he was in Boston. I'm in Boulder, Colorado. We were working with a palliative care physician, and my grandfather's wife kind of let me kind of be the point of contact. Number one, I'm a physician. I can speak their language. But number two, it was her feeling, and I'm assuming this is somewhat normal, that, it's the hospice doc, it's the palliative care doc. They just want to let my family member die. How do you start a conversation with someone who already is defensive about talking to you?
I always talk to them about how, I am not personally invested in what decisions they make, that this is a journey. And if the patient can participate, it should be the journey that they are directing. And if the patient can't, then the responsibility of the decision makers is to make decisions based on what they think that patient would decide. And so I try to divest myself of, I say, we're in a place where there's no right or wrong. Some people want to fight to the bitter end. Okay, there's consequences to that, and decisions have consequences. But if that's what you want, we do that. And other people just would not want to live like this. And again, we can assure comfort. We can, when the time comes, we can have a timing so family can be there if they want to, and, hopefully try to wake the patient up if possible for a short period of time. But I really emphasize that I don't have an agenda other than to clarify the plan of care and to make sure they have all the information they need to make an informed decision.
Yeah. Talk about the training path to be a hospice and palliative care specialist. You mentioned your path through internal medicine. I'm assuming there are other paths to get to kind of where you're at now. What does that look like?
When hospice and palliative care became an official board certification as a subspecialty, it had more medical groups or specialties sign on to have that as a fellowship type program than any other. Wow. I think the one before that was emergency medicine. And I want to say there was like 11. I had these numbers in my PowerPoint, which I don't have, but it was like 11 different boards, anesthesiology. I mean, some of them you expect, but general surgery, neurology, psychiatry. A lot of groups felt like this was an important subspecialty to have. Initially, and I'd been doing it so long, we had our own make-believe board certification that was just from a hospice, a palliative care organization. But there was a lot of politicking to get official board certification recognition, and that happened. And now there are a large number of groups. It is a fellowship now. You can't grandfather in, which is what I did, though I've subsequently taken the certification exams. It's normally a one-year fellowship with the option of a second year to kind of focus in on things like pediatrics or research, things of that nature. So it's not hard. In fact, I was surprised that, my son has shadowed me in the past, and he decided he wanted to go into radiology. And as I was kind of getting up to date on all this, I found that hospice and palliative care is in fact a subspecialty of radiology. So I still have hope for the child.
That's awesome. Patrick asked a good question here. How do you manage the attachment to your patients, knowing that they're a lot of times kind of on their way out?
You have to, and it's really not a field for everybody. Both nurses and doctors and the nurse practitioners and PAs in this field, there are many who burn out because of that. You get attached to these people and they die, and you can only do that so much. In order to do it successfully, you really have to have a significant mind change. So is my goal to cure this patient? No. Is my goal to improve their quality of life? Absolutely. And so if I'm successful there, I've been successful. Is my goal to help them have a death when that time comes that is comfortable, that is in the place they want, not in an ICU, but at home most of the time with family available and with their symptoms well controlled? If that happens, if I can achieve a good death, so to speak, that is, for me, that's the reward. Everybody dies, right? Everybody dies. So you love them oftentimes, not always. But the fact that you have been able to have a significant impact on that end of life experience, for me, that's the reward. And is it, do you miss the folks? Yes. Do you need some kind of release outside of the career? Absolutely. But I go, it's like that very first patient I described. If I go home at night, and I've just had a cancer patient come in and say to me, I haven't felt this good in years. I'm doing things I've never done. You've given me my life back. And literally, I had a patient tell me that just a month ago, just came in bouncing. Is he going to die? He is, but he's not going to die in pain and suffering like he has been for years. He's going to have some quality to his life. And you've got to accept that that's the reward here.
Yeah. I'm going to start bringing some students on if you want to come ask some questions with Dr. Chamberlain. Please raise your hand and I'll bring you on. What's a day in the life look like as a palliative care specialist? You mentioned doing house calls. Is that kind of a norm these days, or is it kind of what you make of it, whether you're in a hospital or in nursing homes or in patients' homes? What does that look like?
Yeah, it very much depends on where you have decided to focus your career. As I said, originally, probably, if you're just working with hospice, you spend a lot of time in meetings, but then you also, normally there's a lot of nurse practitioners right now, PAs are working on it, but that work with and do a lot of the house calls. But I would do frequent house calls, especially if there were symptoms or issues that we didn't feel like we could address. So that I found that a little bit. I like the house calls, but if you live in a fairly significant metropolitan area, traffic and driving, and I could spend all day and see 3 or 4 patients and spend hours behind the wheel, and I'm not a person who loves driving anyway.
Yeah.
So that's not, telehealth is going to change all of this. This is, telehealth has been a terrific boon to especially palliative care, I think.
Yeah.
For the past 3 years, I was offered a job which was supposed to be helping with a hospice agency associated with the hospital system. And they had a beautiful inpatient hospice. And between the time I interviewed and was offered the job and the time I actually got there, the hospice CEO had gone to a convention where they learned that every successful hospital has to have palliative care. So I was abruptly and without my knowledge changed to being an inpatient palliative care doctor. Mm-hmm. And that day is actually pretty nice because it's, you're working on a schedule. We would get consults, a lot, as I said, in the ICU, but I got a number of consults from surgeons to help them with their postoperative pain. And a lot of times the orthopedics folks that have, a very elderly patient with a broken hip, and we need someone who can really talk to the family and decide, do they want to go through this or not? Mm-hmm. So we would have consults. We would follow the consults until we'd achieved what we wanted to achieve. A lot of it was advanced care planning and talking to them about living will and healthcare power of attorney. And also in every state I've worked in, they've had some version of the POLST form. I enjoyed that a lot. I worked with a nurse practitioner who was kind of new in the field, so I'd spend a lot of time teaching her. I found it a very rewarding career. Unfortunately, COVID killed it because hospice or palliative care in a hospital, the data shows that it saves money overall for the hospital in terms of medication costs, in terms of hospital readmissions and satisfaction scores. It does a lot of great things for the hospital, but if you look at it in a silo, what we earn versus what we cost in terms of salary doesn't equal. So all these hospital systems got hammered financially from COVID, and finally they said, this has got to stop. So my current job, I work in a clinic only with cancer patients. It's a cancer clinic. Mm-hmm. So I've moved from primarily doing advanced care planning to now it's almost, I do advanced care planning, but the large part is pure symptom management. And it's surprising how poorly most doctors do pain management, but also other types of symptom management. There's this focus on the disease and the patient sort of incidental. And mm-hmm. I actually, when they come to see me, they're like, I don't know why they sent me to you. And I say, well, your oncologist is about treating the cancer, and I'm about treating the rest of you, to make sure that as that cancer is treated, you have the best possible quality of life. And people are very grateful for that.
Yeah. There's a good question here that I think is a very common, I don't know if misconception is the right word, but I think the wrong tactic and kind of in the grand scheme of life, why we have so much divisiveness between political parties and in our world. This question says, I'm a nurse in both acute and long-term care. I've come across families of patients who hold power of attorney who refuse to change the advanced directives. How do you take the approach to, quote, change their minds, especially when their mother or father are at the end of life?
The best thing I can do is I try to talk to them in terms of what their role is as a power of attorney. That in that role, you are not intended to enforce your opinion and your wishes, but you are acting in the stead of the patient. Your job is to say, whether you like it or not, what would the patient want in this circumstance? If they could be sitting in, and I often use it, I say, if the patient could sit in the chair and look at themselves right now, what would they want? And that is often helpful because it kind of takes the burden off. Sometimes there are some obnoxious people out there. And it's sad sometimes when you've got the information, you know the patient's wishes, and you've got some kind of pushy child. And sometimes there's some secondary gain there. Like, I'm living with mom and I'm picking up the Social Security check. And I mean, there can often be secondary gain. There's also often guilt. And it's kind of a joke inside the hospice and palliative care world that when you're taking care of a very sick patient, at the critical moment, usually the daughter, and I live in Utah, so we would always say it's the daughter from Florida who shows up, and they haven't been involved with mom. They haven't had a chance to kind of see the progressive decline, and they have a little bit of guilt about that. And the way they try to get through that guilt is by suddenly becoming very aggressive. Well, we've got to do this. We've got to do this. We can't let her go. And it's very unfortunate. And the interesting thing is I was giving a lecture on this in Boston, and I kind of said, yeah, then the daughter from Florida shows up, and people say, no, it's the daughter from California. So it's clearly an event that's out there that the child who has not been involved wants to demonstrate their love. And again, there's a lot of psychological context here, and you can't understand all of it in a bite, but to try and help that person to understand that in their case, the love is to help the patient get what they want rather than being an active intervene and let's change the plan of care and how dare you people let mom get as sick as she is. So that's often a series of conversations, but that's kind of the best you can approach it with.
Yeah. All right, let's bring on some students. We got a couple here. We'll bring them on. Let me look at that chat. Any big topics that we haven't covered before we get a student on?
I was, kind of a few things we covered. Income, how much money can you make? And I would say having just been in the job market, we moved here and started this job last February. And depending on location geographically and how much you work, a lot of docs are 4 days a week versus 5. But as I was exploring the job market, I found that it was between 150 and 250 as an annual salary. So it's, it's not, you're not going to get paid like a neurosurgeon, but it's comfortable. And it's really just a remarkably rewarding career.
Yeah. Awesome.
I would also add, in the next 10 years, the number of significant, what we call the very elderly, the 85 and older, that number is going to double.
Yeah.
And they have chronic illness. And as the number of patients, as our population is aging, the number of the proportion or the prevalence of multiple chronic illnesses is going to increase. And a quarter of these folks who are 85 or older have dementia, which is the most expensive chronic condition for the elderly. So in terms of job opportunities, it's huge. I had no problem finding job opportunities because although there are fellowship programs out there, North Carolina's had one and they've now graduated 12 fellows. And a lot of the fellows go into academic stuff. So the actual community palliative care is not as common, but the demand is huge. So if you have the empathy, but the ability to draw a line, it's a terrific career with lots of opportunity.
Awesome. Patrick, hello.
Hello.
Hi.
Can you hear me?
Yep.
All right. So, Dr. Chamberlain, my question was, what do you think about the recent legislation that some states and countries have had about the right to die, or, assisted dying? Some people call it euthanasia. Do you, think it's a good thing or a bad thing, or do you worry that some people might get pressured into, maybe ending their lives prematurely if they're a burden to their families or something?
We need grandma's inheritance.
That's right.
Yeah.
I don't want the Social Security check. I want the house. Yeah, that is a definite hot button issue in the community. I have never worked in a community or an area where there was right to life or right to death availability. Do I have concerns about it? Yeah, it's kind of like, and this is not a great comparison, but medical marijuana. My state has that, and I am required, they have to come see me face to face, and I certify that they have a condition, but I have nothing to do with what they get, what their dose is, how long they take it, how many friends they're giving it to. I shouldn't be involved in that loop. It's not a medical issue anymore. And I kind of feel the same way about the, physician-assisted suicide. My Hippocratic oath had nothing to do with helping people die. Now, have I, in the sense that I've had patients with such severe symptoms that we couldn't control them short of basically sedation. But there is a fine line, and it's based on what is your goal. I do palliative sedation to help provide comfort for the patient. That's my goal. It's kind of, I don't know if you've heard of double effect, but if my goal is to help them be as comfortable as possible, and I'm going to do whatever I can so that they don't die. So I'm going to wake them up, or I'm not going to always put them in a coma. I'm going to just take them down to the point where they're comfortable. If we do it down to unconsciousness, we're going to wake them up intermittently and see how it's going, as opposed to my goal here is to give you medicine so that you can commit suicide. I don't feel like that's my role. And I'd be very uncomfortable. In fact, I wouldn't. I would have to defer that to somebody else, because I feel that a physician helping someone die is, I don't like the ethics of that. When it all started, it was about pain management. What about people who have intractable pain? And the reality over time is that the vast majority of people who do this are doing it because they don't want to be a burden. It's not symptoms. It's kind of an emotional thing. And I can relate to it. I can understand it. But I just don't know that it's my role to, help them do that. Does that make any sense?
Oh, yeah. A lot of sense. Yeah, it's, I don't really have a strong opinion on it either way, but yeah, that's some good insight.
Yeah, so I'm in Colorado where we do have a right to die law that was passed a few years ago. And there's something about it just in my brain logically that I like that it's there and available just in case. And obviously, I hope that I'm never in that position. But it's nice to know, and as you mentioned, right, Dr. Chamberlain, is a lot of it. We always use that intractable pain, right? You have this brain tumor, and you're in intractable pain, and is that how you're going to want to live? And that's always like the fringe argument, right? If we look at a bell curve, that's way a couple standard deviations out there. Not to say that it never happens, right? And so if I was that fringe case, I'm like, yeah, I would like that option, other than many other more not so nice ways of going. So
yeah.
I don't know. But that's the beauty of this world, is you as a physician can say, awesome, great, I'm glad it's available, but I don't want to take part in it. I'm going to be here for my patients. But my colleague is perfectly fine taking care of that.
And that is, I mean, I do believe that people have the right to kind of guide their course, and I would not hesitate to refer if that's what they really wanted. It's just not something I want to participate in.
Yeah.
And I have had a few patients go off to Oregon, and, you know, I've helped connect them with the organizations. But yeah, for me, I feel like often it's because people are not getting their symptoms adequately controlled. And although, you know, there's the burden thing, but you're less of a burden if you feel good and you can do more. So I just, so often, I mean, throughout my whole career, I would be referred to see a patient, and they're just not on a good regimen to control their symptoms. It's not being done well. Hence the need for good palliative care, because I think with good palliative care, the demand for that would probably decrease.
Yeah, it seemed like an easy way out, you know, for better or worse.
Yeah. Well, you know, until you walk in their shoes, I don't know.
Mm-hmm.
I've suggested to my wife that a pillow might not be a bad idea if I get to that place. But, you know, you just have to really understand what are your own boundaries and not inflict. I try very hard not to inflict my goals and values onto my patients. You've got to separate from that and help them get to the place they want to be, whether it's something you agree with or not.
Yeah.
Awesome. Thanks, Patrick. Good question.
Thank you.
It's a great moral, ethical question for medical school interviews. Here's some thought process behind that. A couple other people have raised their hand. I've tried to bring them on, but maybe they're having some tech issues. Not that you would know anything about that.
It's in the air right now, I think.
It is in the air. The computers are having a case of the Mondays. Let's bring on another person. Just raised their hand. We'll see if it works. All right. Let's see. Your computer came up.
Yeah.
All right.
So we probably won't see the PowerPoint, but I can flip through it and make sure I've hit all the points I want to. Let me just log in here real quick.
Yep.
At least it's letting me log in. Whether it will work after that, I don't know. But okay, we'll let that happen.
Yeah. Brock has a good point, and I think that's kind of what we had said. Perhaps it's necessary for both stances to be fulfilled by physicians, both kind of the whole right to die stance. Those against doing everything they can from their perspective, and those willing, taking the reins when necessary. As someone who's seen hundreds of dementia patients pass, there's certainly a point where there is little that can be done. So, yeah. That's
it's, you know, there's things that sometimes you just don't understand. Just, you know, why do these folks with advanced dementia have to linger so long?
Yeah.
I don't have an answer for that, but I don't know that my helping them kill themselves, or in case of dementia, helping someone else kill them.
Yeah.
It's just not something I'm comfortable with.
Yeah. What is your stance on so-called, and this is a very politicized term, death panels? When the Affordable Care Act was being talked about, the one side of the aisle started talking about these death panels and talking about other countries that have more universal socialized medicine, kind of regimenting their care, especially for those at the end of their life. And we have lots of data, I think, that shows that lots of money is spent at end of life. What are your
amount.
thoughts on that?
I think in a sense, I don't like the death panel concept, but in a sense, we're already there. I took care of a young lady with, 3 young children who had end-stage cirrhosis because of her alcohol use, and she was denied a liver transplant because of the high probability that she would continue drinking and would just kill off the transplant. We are in a world of limited resources, and it's very similar to in the early days of dialysis when there just weren't enough machines available. And, as I mentioned, the increasing rate or the increasing numbers of elderly patients with multiple chronic illnesses, at this point, we do not have the ICU capability. I mean, we've even seen this with COVID, where, there's very politicized stories, but people who can't get into the ICU because the thing is full. And, the hospital I worked at, we had all these plans for how we could, expand ICU care here and here, but you don't have the ventilators. And more importantly, you don't have the staff to deal with all that. So there are a limited number of beds in nursing homes right now. That's pretty close to maximum. There's nice waiting lines, or not nice, but there's significant waits often for a nice nursing home. So many ventilators out there and no more. I mean, that's it. So it's not so much, gee, you don't deserve it, as you do have to make decisions about what is going to give us the best possible outcome if we have a limited resource. And I think we are going to be forced more and more into that place. And again, our hospital, in conjunction with a number of other hospitals, created a kind of a triage model for if we're have a limited, if we're running out of ventilators, who gets the next one? And it's a horrible thing to have to even consider, and fortunately we never had to, but it's a reality. We have an aging, sick population, and we have limited resources. So yes, I think there is a point where we need to say, you've got end-stage cancer, it's metastatic. We really can't put you on a ventilator and support this when your life expectancy is so poor. It's coming, and we just need to face the reality of that.
Yeah. If you watching want to learn more about this is known as the principle of justice in medical ethics, which is the fair and equitable distribution of healthcare resources. If you want to take a deep dive, you can do a little bit more research on that. But Dr. Chamberlain, thank you so much for taking some time tonight to hang out with us. I apologize for the tech issues and your Mac dying, but we made it. We made it through. It was a great conversation. It lived up to everything I hoped it would be. So thank you for taking some time.
Oh, it's my pleasure. Thank you for inviting me.
Yeah. And for everyone else, thanks for showing up, and we'll see you next time. Bye.